All right, so CHF, so congestive heart failure. So the heart is congested with fluids. There's been some definition changes over the time where we figured out that it's not always just due to a weak heart. Sometimes it's due to a heart that's been hypertrophied pathologically by the patient due to like hypertension or obesity or inflammation. But we'll talk about CHF, its types, its symptoms, and its treatments, and of which there's a lot of treatments, and we have to be aware of those treatments, especially coming from telemetry. We know those treatments, but also those patients in the ICU that need those treatments, and some treatments they don't need because they might be in an exacerbation, a CHF acute exacerbation, and some of the treatments are contraindicated. One of the big ones is beta blockers, right? You wouldn't give beta blockers to someone that is, like this, really, really struggling, because yes, it's going to reduce workload on the heart and reduce those things, but in this chance for the heart to do as much activity as it can, right? Not tachycardia, but we want to make sure that it's ejected as much stroke volume as possible into the aorta, right? And then we'll talk about all that stuff can lead to cardiogenic shock, right? So they can come to the hospital. When you come to the hospital with CHF, and that's the reason for your hospital visit, that's called a CHF acute exacerbation, an exacerbation of one CHF, right? And then that can then lead to cardiogenic shock if it doesn't get treated, or they could just be showing up in cardiogenic shock. Technically, the difference or the symptom, the key difference is the coughing up of pink frothy sputum or pulmonary edema. Going to pulmonary edema definitely means we're not pumping blood forward, we're pumping blood back into the lungs, right? And that can congest the lungs and cause us to have this pulmonary edema. And then we start getting wet lungs. And then since you're not pumping blood forward to the body, body can start clamping down with the S response. You start getting cool and clammy or be in a poor output state, right? And then of course that will then lead to a low blood pressure. So that poor output state and a low blood pressure is the definition of shock, right? So CHF, we kind of think, oh, they just got CHF, but it has a 50% mortality in 5 years, right? So it's a flip of the coin whether someone's going to be here in 5 years or not when they get diagnosed with CHF as an outpatient. We're not talking about the hospital, we're talking about as an outpatient. If they get diagnosed in the hospital or they come in, they just have CHF and no hospitalization for 5 years, 50% chance they're going to make it. But if they have a visit to the hospital with CHF exacerbation, it's a 75% mortality. So only 1 out of 4 people will survive in 5 years if they get admitted. And each time they're admitted, that drops dramatically. So it is almost as worse as like cancer diagnoses. Like testicular cancer has a 75% mortality or survival rate, right? So if you have testicular cancer and CHF, I'd rather get testicular cancer because I have a 25% survival across the board with testicular cancer, right? Esophageal cancer has a 5% survivability, 95%. We're not gonna get close to that, but we're getting up there as far as here's 29% ovarian cancer. It's the same mortality if you have CHF or not, right? So it's an incredibly, not pervasive, but it's incredibly high mortality chronic disease that we have to pay attention to and make sure they get as fixed as possible, right? They need to get started on their anti-failure drugs, right? When they get out of cardiogenic shock, blood pressure is good. We can start starting medications that are going to prevent failure in the future. Okay, so CHF again looks like this, right? On the left is a normal heart, and the right is a abnormal heart. So you can see the CHF is barely struggling. It's like our picture we just saw. It's really struggling to produce a cardiac output, right? And of course, that can back up into the lungs, right? If it doesn't pump the blood forward out the aorta, then it's going to start causing that blood's going to back up. And there's all kinds of sequelae that happen, all kinds of consequences that happen because we can't pump the blood forward. It's going to start to remain in the chamber, and that can then dilate that chamber. And then that's going to cause what's called dilated cardiomyopathy, technically, right? But we name it now heart failure with reduced ejection fraction, right? So this is what I was talking about. Here's our dilated cardiomyopathy. Here's our heart right here. You can see how thin these walls are. They're extremely thin. And do they have myocardial rupture? Not so much. As they get really thin and more thin and more thin, they just eventually give out. They can't really pump out an effective blood pressure or effective stroke volume, which makes up our blood pressure, right? Blood pressure is a function of the blood that expands this aorta, right? That is what you're measuring on the cuff, right? You're measuring how much expansion is there during one cycle versus another cycle, during systole versus diastole, and you can measure that, right? So that's the amount. If you have poor stroke volume, you're going to eventually get a poor flow of blood and poor blood pressure. And when you have poor blood pressure, now the S is going to kick in, right? And that's going to then clamp down more. It's going to be even more difficult to output blood. All right, so CHF is the failure of the heart, right? That's what it means, congestive heart failure. Congestive is like an old name for it. Again, in the last 15 years, they've changed it to either two varieties. They call it heart failure with a reduced ejection fraction or heart failure with preserved ejection fraction. And then some guy from Mountaintop came down and said, what about if it's in between? It's like 40 to 50% EF. I want to call it mixed ejection fraction. It's like, go away, Bill. We don't want you, right? But yeah, there is technically another third type of CHF, okay? Again, it's a downward spiral. The mortality is incredible at 5 years, right? 40% to 50% mortality. And again, if you're hospitalized at any one point in that 5 years, you have a 75% mortality. And by age 40, 1 in 5 people get diagnosed. And again, we need to figure out what the underlying cause is. So it could be due to a direct failure of the heart or just strain on the heart. So direct failure we've been talking about with an MI of some sort, right? We get an MI, an MI, an MI, an MI, and we've kind of talked about the reasons why you get an MI. You have ASCVD. What does that stand for again? Atherosclerotic cardiovascular disease, right? If it doesn't cause heart failure, it can cause hypertension. And, oh, cool, I just got hypertension. Well, now you notice that hypertension leads to CAD and MIs as well. And what leads to hypertension? Well, diabetes does too. So all these chronic diseases need to be managed, otherwise it can lead to consequences like renal failure, other things, but it can also lead to failure of the heart, right? And of course, obesity leads to ASCVD. We got smoking itself can lead to ASCVD, and that causes hypertension. Hypertension leads to MI, and smoking leads to ASCVD, and ASCVD leads to hypertension. ASCVD leads to direct damage to the heart, and an MI, which leads to congestive heart failure, right? And then there's some other rare reasons out there. There's cardiomyopathies that can occur. All right, there's dilated cardiomyopathies, which happens with our heart. Normally, start with an aging heart. The walls get thinner and thinner and thinner. Age greater than 65, just the heart just giving out. And then there's hypertrophic reasons when they're usually born with it, right? Or maybe it's Maybelline, I don't know. If they have a heart that is hypertrophic, right? It could be due to diabetes or hypertension or extra strain on the heart. And yeah, is this strain? Yes. When it puts strain on the heart, it's going to go down one of two avenues. We don't really know what it's going to go down, but eventually it's going to cause the heart either build up more muscle and get hypertrophic, or it's going to just weaken out, right? And it will lead to dilated cardiomyopathy. And restrictive is more of a infectious process or an autoimmune process, where you have like a collagen disorder, where you have like lupus, or you have like amyloidosis and something that's going to cause a invasion of the heart, like Chagas disease in South America, right? The kissing bug will kiss your lips in the middle of the night, and then that's going to then invade your myocardium, right? And then we have strain on the heart, right? So again, obesity, hypertension, diabetes, that leads to direct damage to the heart and leads to an MI. But if it doesn't do that, it can lead to high blood pressure. And again, it's however the cards are dealt, and your age and your other risk factors, whether you're going to get dilated CHF or not dilated, or hypertrophic CHF, we could say, or heart failure with reduced ejection fraction, or heart failure with preserved ejection fraction. All right, and then E2H is just a hypertensive drug. It's going to cause hypertension, and that's going to, again, put more stress on our heart, more strain on our heart. Valve dysfunction. So if we have a valve if we have a heart that's getting bigger and bigger and bigger right here, so it's bigger and bigger and bigger, that's going to separate out the valves, right? And now we got valve disease. And valve disease is forward flow can be hard, or forward flow gets regurgitant back into the previous chamber. And that's going to make that chamber bigger because it's working harder and harder and harder, or it's getting bigger and bigger and bigger because there's more and more volume, right? And that's going to make your CHF even worse, right? What if we have like aortic regurgitation? We pump all the blood into the aorta and it just regurgitates back into that left ventricle. It makes the left ventricle bigger and bigger and bigger over time. All right, and then smoking and COPD lead to specifically right heart failure. So we're kind of talking about the left ventricle here, but the right ventricle fail as well, right? The right ventricle was going to start hypertrophying over time as you get this chronic smoker, chronic COPD patient, chronic hypoxia, like a long COVID patient, or pulmonary fibrosis patient, or mesothelioma patient. All these things are going to lead to a right heart that's working extra hard, right? And right heart failure is just as important as left heart failure, if not having a stronger mortality. Okay, and then pericarditis, myocarditis puts a lot of strain on the heart, especially if they have recurrent episodes that can lead to failure of the heart. And then endocarditis leads to valve dysfunction. You have this infectious process developing on your valves, and they don't work good. They either get stenosed or regurgitant, and that's going to put extra strain on the heart, right? Especially if it's repetitive or especially if it's not treated. All right, and the progression of CHF, again, as an outpatient, it gets, hopefully gets diagnosed as an outpatient. They can start on their goal-directed medical therapy, GDMT, or they can start on their anti-failure drugs, right? So GDMT is another thing you might see written in like a progress note by the cardiologist, goal-directed medical therapy. All right, they start on the anti-failure drugs, and there's a whole host of them. There's about 4 to 5 of them that usually patients are going to be on to get set up before they get discharged. To say, I need to start on these medications, they might, taper them on, but they'll definitely need to be on these meds to stop the underlying process that's causing their heart failure and stop the heart failure from getting worse, because your body's actually going to cause more damage than good. When your heart starts failing, it's like, oh, I know how to fix that, and you realize it really does not know how to fix that. It's going to cause more problems than good. Okay, and we mentioned CHF, if they get to the hospital setting, that's a CHF acute exacerbation. And there's all kinds of different reasons why that could happen. It could just be just an infection, or it could be someone goes into AFib RVR. AFib is going to knock out the atrial kick, right? Your atrial, put about 10 to 20% of your stroke volume is that, and of your cardiac output for that matter, is your atrial kick. Someone goes to AFib or someone goes into junctional rhythm, they lose that 10 to 20%, and that might have been that was what was needed to support the blood pressure, right? And now your blood pressure is not supported, now the SNS kicks in, now you're vasoconstricted, and now the heart's even working harder, and that's going to be a downward spiral, right? So you can see here, systolic heart failure versus diastolic heart failure may have been heard being thrown around. That was really hot in the 90s, right? But then that phased out into what's called HFrEF, heart failure with reduced ejection fraction, or HFpEF, heart failure with preserved ejection fraction, right? So this is technically HFrEF over here. HFrEF versus HFpEF, right? So those are 2 types of heart failure that we're dealing with. Or you got that guy from the mountains that says, well, about heart failure with mixed ejection fraction, right? But or that either way, when you have reduced ejection fraction or systolic heart failure or classic heart failure that's been known since the 1800s, it's like, oh, you have congestive heart failure. Why they call it congestive? Because their lungs sound congested, right? So they have this, that was what was known up until the 90s when they discovered that, oh yeah, there's actually another type called diastolic heart failure. But our classic heart failure that you learn about, like left heart failure versus right heart failure, that's all a derivative of systolic heart failure, or the new one on the block, HFrEF, right? So you have HFrEF, you have a decreased cardiac output and a low stroke volume, and that's going to lead to low blood pressure. You have low blood pressure, that can just straight up lead to low coronary perfusion pressure and lead to NMI. And now you're back to square one, where you have a heart that can't pump good, right? And now you have low blood pressure. And if you have low blood pressure, you're going to have compensatory vasoconstriction. Who's going to be firing off at this point? That's going to be your sympathetic nervous system, right? That's going to fire off, and that's going to vasoconstrict. That's what it's designed to do. Say, hey, blood pressure low, I vasoconstrict. And I also try to raise the heart rate, and I increase respirations, all kinds of the fun stuff. But that's what the SNS is going to do. And also who gets triggered is angiotensin II in the RAAS system. So we're going to be introducing the RAAS system. It's very, very popular. It's something that's going to definitely kick this off, and something we want to stop because we realized it actually causes more problems than good, right? Obviously, it's going to vasoconstrict. That's what angiotensin does. It tenses angios. So it's going to cause vasoconstriction, and that's going to be extra work for the heart. So we give medications that block the formation of angiotensin II, called what? ACE inhibitors, right? They block the conversion from A1 to A2, and that makes sense, right? It's going to help reduce blood pressure, reduce the workload that the heart has to pump up against, right? And that workload is defined as what? What's that? What does it have to overcome over on the other side of the aortic valve? Diastolic blood pressure, right? Systolic blood pressure is what you have to squeeze, right? You're squeezing, and it ejects, and you get a systolic blood pressure. And then that will then go into the periphery, and then you have to overcome that for the next cycle. So if that diastolic blood pressure in the next cycle is higher, now your heart has to work harder in the next cycle, right? And if the SNS and RAAS are kicking, then that's going to make it even worse, right? It's going to put even more workload on the heart. All right, and then what you get progressive dysfunction of the heart, because this SNS and RAAS actually cause your heart to remodel itself inappropriately, and it causes a further dysfunction of the heart. So we'll talk about this in more detail. Okay, but either way, someone has some kind of event that puts them on this downward spiral to go into a heart failure, right? So they have a CHF exacerbation, and you can see that their trend is, again, their mortality is extremely high when they get more and more CHF exacerbations, whether it be a simple influenza or a pneumonia, or they get a DKA, they get a myocardial infarction, they don't take their medications, they can't afford their medications, they continue smoking, they don't fix risk factors. All these things can put them to keep being admitted with CHF exacerbations, and every single time your heart does not get better, it always stepwise gets worse. We don't know how much worse it gets. It can go all the way from 100 to 0, or let's say 70% EF to 0%, where you're in cardiac arrest, or it can lead to like a 20% EF or 10%. We don't know, but it's definitely going down, right? You don't recover heart muscle. Heart muscle is the heart you're born with, right? You don't make new myocardium. Okay, at that point you need a new heart. You need a heart transplant, right, to fix someone. So heart transplants are for those that can follow all their medical therapies and also have quit all the risk factors, and of course they're age less than 65 and they have other things that they can do, and they meet criteria and they get a donor heart that they can then get a transplant done, right? So there's all kinds of precipitators that can lead to the CHF exacerbations. And of course, we get them through it, hopefully. If they have influenza, we'll get them through the influenza. They might need to be intubated. And when you intubate them, that puts positive pressure in the chest. That's extra stress for the right heart especially. So these are things we have to pay attention to. You can appreciate on this guy up here how thin this heart wall is. It's very, very thin and exposed. And that's not going to make a nice seal on that aortic valve, or especially not that mitral valve. It's definitely going to be widening out and causing valve disease. And that's going to put you at more risk for CHF that we have to fix. So those patients have to get a valve replacement. And hopefully that prevents the valve from getting worse, or sorry, the chamber that valve was in front of, from that chamber from getting worse. Otherwise, you're not going to be able to get better, right? That's usually the indication for valve surgery or valve replacement, is they are having symptoms of CHF. They're having symptoms of that EF getting worse, or that chamber getting worse, or they're having poor blood pressure and they get chest pain, shortness of breath, hypotension, confusion. Probably not the hypotension just yet. They're probably going to be in the hospital at that point, but they're getting all these symptoms where they have exertional dyspnea. They're walking, and they can't progress anymore because the heart is failing, right? And we can classify that. We can classify, you have that shortness of breath at rest or shortness of breath after walking, right? It's like the New York heart classification, right? Like stages 1 to 4. You just kind of look at it as, oh, you're right here. That's where you're at. You have pretty bad heart failure. That's where your baseline is. And the next time they visit, they're down to it's only, instead of 100 feet, it's like 25 feet. Then that's probably time to get a valve replacement, or time to escalate therapy to figure out what's going on for why their heart failure is getting worse. All right, so that's our overview of CHF and the causes and progression of it. So cardiac output, just a touch on cardiac output, because next lecture will be all about hemodynamics. So we have this is kind of our primer to it. We kind of talked about how heart rate affects your cardiac output with bradycardias, right? When you get really, really bradycardic, you can have really, really low blood pressure. The reason is because heart rate times stroke volume is your cardiac output, right? So heart rate times stroke volume is your cardiac output, how much blood you're putting out per minute, right? So yeah, you have autonomic insufficiency, right? You have really, really severe drug intervention, like you're on a lot of digoxin or you're on a lot of beta blockers, that can lower your heart rate, right? Or we have too much vagus nerve activity. Someone is vasovagal, like Elvis, right? They're going to be vasovagal down, and they're going to lose blood flow. They're going to become syncopal, and they're going to have a low cardiac output, right? And then, of course, with age, your SNO just kind of gives out. About age 75 to 85, that's when your SNO kind of goes out, and that's where you would then need a pacemaker, right? So that can contribute to a low cardiac output. So what we're going to focus on today is the stroke volume piece, right? So why do you have low stroke volume? Well, if you think congestive heart failure, if I'm unable to squeeze my heart, obviously that's going to cause a low blood pressure, right? So that's called contractility, right? So myocardial contractility being poor, that's one of our heart failures, right? One of our heart failures are HFrEFs, right? Heart failure with a reduced ejection fraction. It's unable to eject blood, right? Its test score is really poor. You give it 100 cc's of blood, it only ejects 10% of it. It gets a score of 10%, right? So like the end diastolic volume here, so the EDV, end diastolic volume there is 100 cc's, let's say. That's how much you can get on the test, right? I get 100%. But then I study I study my butt off. I'm going to nursing school. I'm stressed out. I'm in clinical 24 hours a week, and then all I get is a 10%, right? All I get out of that test was 10 points, right? That's all I was able to squeeze out of my brain. Only my intellectual diarrhea that morning was only 10, right? So that's all I had to give, right? So the heart is when it's very, very weak, it has a very, very poor test score, and that's your ejection fraction. That's your percent. A normal percentage is what? Just like in nursing school, 70%, right? Once I get a C or better, that's perfect. C's get degrees, right? So that's all I need, 70%. But when I start falling down and down and down to the less than 50%, 40% range, definitely less than 40% is what was called HFrEF, or heart failure with reduced ejection fraction. And that can be all due just to poor contractility. Your end diastolic volume minus your end systolic volume is your stroke volume, how much you're getting out of your heart, right? And what does that look like? So, you're doing a systole and you have a ketchup packet on the table, right? However hard you hit that ketchup packet, you're going to get more ketchup out, right? How much is left behind? That's your end systolic volume, right? How much is left behind after I contract? If that's a lot, obviously not a lot came out. Our test score is based on what came out. That's the stroke volume, right? And what affects that? What makes it so that I can't get a lot of blood out of my packet? Well, yes, it could be the contractility, right? That could be the reason why I can't get a lot of blood out, but it can also be due to, what if that ketchup packet was sealed super tight, right? It's like sealed, double sealed, triple stitched, and it was like, double leather stitch, and it was, I bought an Etsy and looked, it's never gonna rip, right? But then then you go to a con and then it rips on you. No, kidding. So anyways, you have this really, really tight ketchup packet, and you're unable to get the blood out. Even however hard you contract, right? Your heart's like, oh, I can do it. It can barely get enough blood out. You might be able to squeeze a little bit out, but it's super, super tight. That is what's called afterload, right? That's the pressure that you have to overcome before you're able to get the ketchup out of the heart, right? Or you're able to squeeze, you're squeezing, right? That's the contractility, and the pressure on the other side is what you have to overcome. And that pressure is your diastolic blood pressure, right? Because systole is what you're about to create. You're about to eject blood out of your heart, and you're going to stretch these. That aorta right there, and you're going to stretch the brachial artery as well. And that brachial artery, you can measure the NIBP, the non-invasive blood pressure, right? So that's stretch that you're getting during systole, and that's because of the left ventricle ejecting a stroke volume of some sort. That's going to stretch that vessel, and your vessel should be able to stretch. If it can't stretch because of arteriosclerosis, not atherosclerosis, but arterio or hardening of the vessels, that's definitely going to raise my blood pressure, right? Because it's expected to stretch out and comply and be able to, accommodate that blood pressure, but it can't. So all it's going to do is going to raise blood pressure, right? And that happens with age. Our systolic blood pressure goes up, right? And then that stroke volume is going to stretch, and then the valve closes behind you. And now it's your job of your aorta to then squeeze that blood into the periphery, right? It's during diastole, we squeeze it into the periphery. And if our arterioles are super, super tight because of smoking or ETOH or ASCVD, it's all narrowed, that's going to put a lot of back pressure the other direction. You can't squeeze it, right? Just like if you're trying to squeeze into, like our lung example, right? You're trying to squeeze all that tidal volume into a lung, but the bronchus is that small, right? Or you're trying to fill up a tire and you got the wrong gauge, right? You're trying to really squeeze it in there. So that's why it's important to understand that we need to vasodilate this to make it easier on our heart, right? Because why does it make it easier on our heart? That's so far from the heart. Because the next cycle, we have to go back to square one. We have to overcome what the diastolic blood pressure is. And what's diastolic blood pressure? That's our afterload. That's the pressure we have to overcome during at the end of diastole. Diastolic blood pressure is a function of afterload, right? And we can measure arterial-ulnar tone in hemodynamics. That's called SVR, or systemic vascular resistance. How much resistance is there out there systemically, right? That is our what we can measure to see in something we want to bring down in someone that has a heart failure or someone that has a heart that is dysfunctioning, right? Like post-op heart surgery, for instance. All right, so afterload is a key thing, right? Systemic vascular resistance that we want to hopefully reduce and hopefully prevent from getting out of control. So blood pressure, systole and diastole, we mentioned is systole affected by our ability of our aorta to comply. So, and our ability of our vessels to open up. If they can't open up, that's going to make a blood pressure go up overall, right? And then valve opening. So if our valve doesn't open, that's going to put a lot of stress on our heart, right? If the valve doesn't open at all, that's going to make it really hard. They have aortic stenosis, for instance, right? And then going back to the top, preload, right? So we have preload is going to be, I'm not going to have 100 cc's in my pocket, in my packet here, or my heart. So there's not 100 cc's to give. I'm still only going to get 10% out, right? But what affects stroke volume is how much you put in there in the first place. So if I have hypovolemia, that's going to put less volume to eject in the first place. And that's going to then put a damper on how much stroke volume there. Heart rate might try to compensate. It'll try to increase it. Hey, I notice you're not putting a lot of, you're only giving me 50 cc's. So I'm going to double your heart rate and try to match you, right? So that's the cardiac output, is what we can adjust by either changing heart rate or stroke volume. But there's several factors for stroke volume, like we mentioned. We can increase contractility with the SNS. We can increase the blood pressure with SNS and afterload, and we can also hopefully increase preload. When your SNS activates, it squeezes your IVC, and it'll just squeeze some more blood into the chamber to fill the chamber up with preload, right? And so that's someone who's like hypovolemic, let's say. And then on the flip side, they might have too fast of a heart rate. Our ventricle can't fill in time, right? You have 100 cc's to give in 60 beats per minute versus 100 cc's to give in 160 beats per minute. You're not going to get that 100 cc's in the same amount of time, right? It's not going to work. So too fast of a heart rate can also make our preload lower. Other thing that makes the preload lower is this stress over time, right? We have really high blood pressure, and now our heart's starting to build more muscle and more muscle and more muscle, and it's going to start getting hypertrophic. And now when you're age 50, you could fill up 100 cc's, but now you have all the hypertrophy. Now you can only fill up at 50 cc's. It wasn't because you're tachycardic, it's because you played yourself. Now you're hypertrophied, right? And because your obesity or your diabetes, your smoking, your E2H, all these things are what contributed to this diastolic heart failure, right? And it used to be called diastolic heart failure, but now it's called what? HFpEF. So you have a good ejection fraction. Your heart can squeeze great. It's great at that. Like, I'm Arnold, I can squeeze, right? But then Arnold can't fit, 100 cc's anymore. He can only do 50 cc's, right? Because he can only fill a certain amount in that heart when it starts getting more and more muscular, more and more hypertrophied. So that's called a diastolic heart failure. So those patients will also lead to HFrEF with a reduced ejection fraction because they're eventually going to give out. Okay, and of course HFrEF and HFpEF lead to an MI, and MI leads to HFrEF. Okay, so again, our heart's test score is our ejection fraction, and we kind of eyeball that if we want to know what our ejection fraction is. And where do we find an ejection fraction? On the echo. All right, so the pathophys, again, preload, afterload, and contractility. So it's color-coded, so you can recognize which one is affecting which. And as we said, when you have more workload on the heart, that's going to cause ventricular remodeling. And that's kind of one of our key things we want to fix with our medications. Our medications, we want to stop ventricular remodeling. All these different things here are causing ventricular remodeling. All these hormones that get released, we want to stop because they are going to say, hey, I'm going to remodel your heart. It's going to look much better. It's going to look very pretty. All right. All it's going to do is going to, it has, auto open shades. It's going to open, it's going to wash your car for you. It's going to do all these things. And you're like, cool. And they can show you a picture of their portfolio and they show you, it's going to look like this. And then what do you get back? You get this. Right? And they say, hey, I know how to make a heart. And then it comes like, those aren't heart popsicles. What are you talking about? Heart cake pops, right? So it's going to be not looking what it looked like before, and it's going to be ineffective. And they're going to develop HFrEF because of that, because your heart is going to try to increase its contractility when it's trying to turn it on, and now you're going to hear all this sputtering noise under the hood, right? So it's going to cause, this ventricular remodeling causes worsening heart failure. And your body thinks it's doing the right thing because it never knew what heart failure was, after, the 1700s, 1800s, right? Yes, there was alcohol back then. People drank themselves. There was smoking since the 1400s. When did Columbus, 1492? Anyways, so yeah, that was not as popular as it was nowadays. But what's happening? Your heart's like giving out. It's like, I can barely contract. Right? It's barely contracting, right? And then what happens? Your kidney is like, what the heck? I expect a MAP of 65, and I expect it now every second of the day. Why am I not getting a MAP of 65? And it's going to tattletale, and it's going to release the RAAS system, right? So it's going to release renin into the bloodstream, and the renin is going to then activate, what it's going to do is going to go over to the liver, it's going to release angiotensin 1, or in the heart, sorry, the lungs will release angiotensin 1, and then you're going to then convert angiotensin 1 to angiotensin 2, right? And now angiotensin 2 is going to vasoconstrict. Is vasoconstriction going to help this heart? No. That's going to put extra stress on the heart. So here, I helped. No, you didn't help at all. That didn't help someone's underlying heart failure. And then what else does the RAAS do? The renin does. It also goes to the brain and triggers the SNS response. And what does the SNS response do? It's going to also vasoconstrict. And that's not going to help. And since we're all vasoconstricting here, the SNS and the RAAS system also stimulate vasopressin. What does vasopressin do? Presses vasos, right? So it's going to also raise the blood pressure. So these three hormones are at work and are causing a lot of consequences, right? So decreased cardiac output is going to cause a neurohormonal activation. And that's what we're trying to fix. We're trying to fix this increase in SVR. Because all these hormones, they're good at what they do, right? They're good at raising blood pressure, but we don't want them to raise blood pressure because that puts extra workload on the heart. When you're running from a bear or you're bleeding out, yeah, it's great, right? But when you have prolonged or chronic heart failure, that's not going to help out. Okay, so we increase the SNS response, and the SNS response, yes, it's going to increase heart rate. That's going to increase myocardial workload. That's not helpful, especially if someone's at risk for an MI. It's going to increase blood pressure and increase afterload. And that's going to cause a lot of problems. And then also it's going to increase contractility, and it says, hey, for next time, I'm going to sell you on this plan. Like they're going to pull you over like in Vegas for a timeshare talk and say, hey, I can make your heart look just like this, right? And then you say, sure, I'm going to spend 4 hours of my Vegas vacation, and we're going to go ahead and you get this at the end, right? When you actually visit the timeshare, right? So that's not what I expected. And then it causes this ventricular remodeling, which is ineffective. It's going to cause a further degradation of someone's heart failure. Okay, and of course, when you raise the blood pressure, that's also going to make more SNS and trigger the remodeling of the heart. All right, and then SNS directly stimulates the RAAS system. The low blood pressure stimulated the RAAS system, and the SNS stimulated by low blood pressure also stimulates the RAAS system. So they're both tag teaming it. They're both getting themselves involved in the problem when the blood pressure is low. And that makes sense when you're bleeding out. But when you have CHF, it doesn't make too much sense, right? We want to support the heart as much as possible. All right, so then the RAAS system, or the renin-angiotensin-aldosterone system, right? So the RAAS system is due to the SNS, as we mentioned, and also due to directly low blood pressure or low flow to the kidneys. When the kidneys don't get the flow they need, they are going to release what? Angiotensin 2 eventually, right? They're going to release renin, specifically A1 to A2 by ACE enzyme, and that's going to raise the blood pressure. What else does angiotensin 2 do? It's going to stimulate the release of, yes, the SNS, yes, vasopressin, but also stimulate the other A in this equation, which is aldosterone. And aldosterone thinks it's helping, especially if you're running from a bear, you got attacked by the bear like Leo, and you're on the floor and you're bleeding out, right? You don't want to be losing any more blood volume than you already have, right? And you want to retain blood. You don't want to be peeing extra urine right now. Let's take that volume I was peeing out and put it back in the system, right? So aldosterone, it's going to go and take sodium from the urine and the nephron and put it back into the bloodstream, and then water is going to follow sodium, right? And that's going to raise my circulating blood volume. And raising circulating blood volume, is that going to help someone who's already fluid overload? No. So this is why also we give things that block angiotensin 2, because we know angiotensin 2 is going to cause that to happen. And also we can give medications that block the effect of aldosterone on the kidneys, because we don't want to retain any more volume right now. We want to vasodilate as much as possible. We want to have a nice adequate preload. We don't want to have extra preload, which is what aldosterone would do normally, right? As we mentioned, angiotensin 2 will do that, but it also will ventricular remodel. It will also directly remodel the heart. It will also stimulate SNS to remodel the heart, right? And then we have ADH, so antidiuretic hormone, and it has like 6 different names. It's in witness protection, and it has, so it's called ADH or vasopressin or DDAVP or LD arginine vasopressin. Has all kinds of extra names and passports when you actually find it and corner it. Either way, what does vasopressin do? when stimulated by the SNS and when stimulated by the RAAS system and when stimulated independently by low blood pressure, right? When the blood pressure is low, that's going to cause ADH to be released. And that's going to help squeeze down because vasopresses, and also it's going to anti-diurese. What does anti-diurese mean? It's going to retain fluid. And that's not going to help someone that is trying to unload fluid and vasodilate, right? That's what's going to help the heart. All these things are hindering the heart. And the last piece of the puzzle is ANP and BNP, and these guys are actually the good guys. These are the ones that we want around because these guys are natriuretic peptides. What does natriuretic mean? Na means sodium. Uretic means pee it out, right? Sodium in the urine. So these guys, ANP and BNP, are released when my heart stretches, which it's going to do. It's going to stretch and stretch and stretch, and they are going to get released, right? They called it BNP because they thought it came from the brain, but nobody wants to admit fault. So they still call it BNP, even though it comes from the atria and the ventricles. So ANP and BNP are released from the atria and the ventricles when they are overstretched, and they are going to try to help that problem. What they know to do is go to the kidneys and say, get rid of some salt, please, right? So they get rid of salt, and then your blood pressure, your volume decreases, and hopefully that reduces stretch on the heart, right? So it's great. They increase sodium water excretion, reducing preload. All right, they are going to fix this problem where we have the extra blood volume, right? And the other thing they do that we come to find out is they actually inhibit the RAAS system. Well, that's great, right? The RAAS system is causing all kinds of problems. So let's inhibit the RAAS system, right? It turns off the RAAS system, and therefore we can, the RAAS system triggers the SNS, so therefore you have decreased SNS activity, decreased RAAS activity, decreased blood vasoconstriction, therefore blood pressure is better, and also we have a decreased ventricular remodeling, we have decreased all kinds of fun stuff that we want, right? So we have medications that will actually upregulate ANP and BNP. These medications are going to increase them, okay? So this is the reason why we prime you with this, because this is all going to relate to the medications and also relate to hemodynamics when we talk about afterload, preload, heart rate, contractility and such, right? Inotropy or chronotropy or dromotropy. All right, so I apologize if you feel like this right now. All right, so right versus left heart failure. So again, this was what it was described before the year 2000. And then in the 90s, it got really popular to call things systolic heart failure and diastolic heart failure. But these left versus right heart failure only is applicable to HFrEF or systolic heart failure. That's when you can say, oh, they have left-sided HFrEF or right-sided HFrEF. This does not apply to HFpEF or heart failure with preserved ejection fraction. This happens when your heart can't pump blood forward. Therefore, it all backs up where? In the lungs, right? And if it's a left heart failure, I should say, or left HFrEF. So this is an SAP, so standard anatomical position. So if we talk about the left side, which is usually the most popular side, right? So if our left heart is not pumping blood to the body, to the system, right? So it's not pumping blood forward, what's going to happen? It's going to then back up into the lungs, right? And we get what symptoms? We get dyspnea on exertion. Worst case scenario, yes, you can get pulmonary edema. That pretty much means you need to be admitted to the hospital, you have CHF exacerbation, right? But at first, what they're going to complain of, they say, I got dyspnea on exertion, I got DOE, right? So that means they're walking, and get short of breath. If they're walking, get chest pain, what do they have? Stable angina, right? But they're walking, get pain in the legs, what's that called? Intermittent claudication. But if they're walking, and get dyspneic on exertion, they could have COPD, or they could have CHF. You got to look at them, and you can kind of eyeball what a COPD patient might look like versus a CHF patient, right? So dyspneic on exertion is a sign of the lungs filling up with fluid because the heart's kind of giving out. Oh, and it gives out over a certain amount of feet, and then it can then fill the fluid up in the lungs, and that can then cause dyspnea on exertion. And oftentimes at rest, they'll have like a dry, hacking cough. They're coughing all the time because the fluid is in the lungs, and that's an irritant, and then they're going to be coughing all the time. And then crackles and rales can be also maybe in the lungs and the in the bases in the lungs, and then that can then progress all the way up until they are coughing up what? Strawberry smoothie from Jamba, right? They're getting pink frothy sputum. And you can see this in someone's ET tube in the ICU. When you suction them, you can see, oh, why is it pink frothy, right? Then you're included, oh, you get like a core memory like Ratatouille. Whoa, pulmonary edema, right? So that's what it was. And then oftentimes they'll cough it up into the Ballard suction device. You'll be able to see that filling up with red blood. Yeah, it could be a tumor that ruptured, or they could have a traumatic, too much suctioning, but sometimes the picture all equates when they have crackles and everything else, right? And then when you have low cardiac output, because you're not pumping this blood forward, you're going to have symptoms of low cardiac output. And again, that's chest pain, shortness of breath, which you talked about, hypotension, and confusion. So the hypotension is what kind of puts us on a pathway towards cardiogenic shock. They will start compensating in the meantime. And how do they compensate when the blood pressure is low? Like from the previous slide, they're going to do what? They're going to RAAS and SNS and ADH and Vasopressin. All these things are going to vasoconstrict. So their extremities are going to feel what? Cold or hot? They're going to feel cool to the touch. They might be diaphoretic too, because that's the SNS activating, right? So they have cool extremities, and they're going to start going into, when the blood pressure is getting less than 90, they're into cardiogenic shock. Usually cardiogenic shock technically is defined as that poor output state. They're still compensating, and then they can then decompensate to low blood pressure. All right, and then yes, the heart rate might be elevated. They might be thrown into AFib RVR, and AFib RVR can help the situation. No, they already had a poor cardiac output. You go to AFib, you lose the atrial kick, which supported some of our cardiac output, right? And then yeah, urine output can be low, but they're not going to always tell you that. You can't like assess it. Hey, what's your urine output? All right, they're not going to always report that. My urine output is 45 cc's last hour, sir. All right, they're not going to read, but they're going to definitely report, I have chest pain, I got some shortness of breath, and I walked only 10 feet to the bathroom. All right, that's going to explain that they might be CHF that's on your hands, right? And this paroxysmal nocturnal dyspnea, they might say they get short of breath at night versus during the day they're okay, but at night it gets worse. And then they have extra heart sounds, not heart murmurs, but heart sounds. And yes, a murmur is a sound, but it is an S3 or an S4, right? S3 is seen classically in CHF. So you can think of CHF as 3 letters, so that's S3 is what you see with that. And with S4, that's with a hypertrophied myocardium. And yes, we have a hypertrophied CHF, and that's called HF what? HFrEF or HFpEF or HFmEF? HFpEF, right? So HFpEF, or preserved ejection fraction, that's where they have this hypertrophy of the ventricles, and they eventually get this S4, right? And we'll explain why that is when we talk about murmurs. Okay, so that's the idea behind left heart failure, right? We can't pump the blood forward, therefore it all backs up into the lungs, right? And we get classic symptoms of pulmonary edema. Now what about the right side, right? So the right side, we're not pumping blood to the lungs efficiently because our lungs may be vasoconstricted. Why would the lungs be vasoconstricted? They have widespread pulmonary vasoconstriction because of what disease process? No, hypertension. Hypertension affects the arterial system. Pulmonary hypertension, what's that? Pulmonary edema? Yeah, pulmonary edema technically is a pulmonary hypertension. And yes, left heart failure is the most common cause of right heart failure because now you put all this fluid and blood into the pulmonary circuit, and that's a lot of extra work on my right side, which is not used to that, right? If you look at the wall of left versus right, the right is much thinner compared to the left, right? Or much less muscular. So what causes widespread pulmonary vasoconstriction is a widespread hypoxia or widespread hypercapnia. So a COPD patient, for instance, or a pulmonary fibrosis patient, or a cystic fibrosis patient, or an obese patient, because they're obese, they are too wide to breathe, right? So they have all this extra fat tissue and adipose tissue on their chest, and at night they get this hypoxia chronically, and that then puts extra stress on the right heart eventually, right? So yes, left heart failure, most common is from the right heart. Left heart failure is the most common reason for right heart failure, but you can get right heart failure independently, and that's called cor pulmonale due to lung pathology, something in the lungs happening, right? COPD, obesity, long COVID, all these things independently cause right heart failure, for my right heart to fail, right? But left heart failure is the most common cause of right heart failure because all that fluid was filling up in the lungs because the left heart wasn't pumping it forward, and now that's extra work for my right heart, and therefore I can't pump blood forward into my lungs. So then what happens? It backs up. Where does it back up into? It backs up into the neck, right? So it backs up into the neck, right, and causes JVD, right? It backs up into the liver and causes what? Causes hepatomegaly. Backs up the spleen, causes splenomegaly. Backs up into the gut, right? So it causes gut, it causes ascites. It also causes them to have nausea, vomiting. They don't want to eat, or anorexia as well, when you don't want to eat. So they feel like they don't want to eat for a while. They're like not hungry all the time because their GI tract is full of fluid, right? They don't have the will to eat. It's not going to make them nauseous, for instance. And then it could back up all the way into the what? Into the toesies, right? And cause a dependent edema, right? Versus anasarca. It's not going to cause anasarca. Anasarca is due to low protein counts, right? Whereas this is a dependent edema because of too much hydrostatic pressure, too much fluid just pushing its way into the dependent extremities, right? So we got that dependent edema. We have the hepatosplenomegaly, and they have the JVD, okay? And we can measure that with CVP, or central venous pressure. We can get it reading off of them for that. All right, so as we mentioned, JVD, we got hepatosplenomegaly, we got poor appetite, nausea, vomiting, we got dependent edema, and usually one of the teaching things is you don't want to gain about 2 kilos, don't want to gain about 5 pounds in a week. That's going to be a situation where you are retaining too much fluid. The other important piece is that this also backs up into the kidneys. So it's a newer concept the last 10 years or so is that the heart failure leads to renal failure, yes, because you can't pump blood to the kidneys, but also all that fluid's backing up into the kidneys. And for the kidneys to unload, it needs to be able to unload the blood. If it can't, it's all going to get congested and cause failure in of itself. And we'll talk about that more in renal. All right, so diagnostic tests and classifying CHF. So as we mentioned, we have preserved, or HFpEF, and we have preserved. So yeah, so sorry, I circled the wrong one. So ejection fraction that's preserved, HFpEF, and ejection fraction that is reduced, or HFrEF, right? So the line in the sand is usually about 40%. And now with the new guy from the mountaintop, he wants to call it mixed or both ejection fraction, or HFpEF or HFmEF, right? So that's like 40 to 50%, but we won't get into the details of that. All right, so again, diastolic heart failure, or HF which? Diastolic heart failure means the ventricles can't fill with blood because they are super, super beefy. That's a diastolic heart failure, or HFpEF, right? They have a preserved ejection fraction until they don't, right? It gets more and more beefy and beefy and beefy, and then until it leads to a HFrEF. Okay, and then what else? So, and they actually found out that HFpEF, or diastolic heart failure, is actually like 85% of CHFs. And it's that 15% where they're on a downward spiral towards a higher mortality, right? And then left versus right heart failure, just to recap, those that only describes HFpEF, or sorry, I keep saying it wrong, sorry. It only describes a reduced ejection fraction, okay? So when you have a preserved ejection fraction, you don't have symptoms. There is no symptoms. You might have high blood pressure, right? And then when they finally do an echo on your heart, they realize, oh shoot, look at your heart, it's all HFpEF'd, right? It's all concentric and hypertrophied, and you're at risk for this getting worse into developing MI or even HFrEF down the line. So they give them stuff to control their blood pressure, right? And then what else? Severity of symptoms. Again, the only purpose of this, you just look it up as far as what stage they're at, and that can tell you if maybe they need valve replacement, or if they need an increase in medications, and that's more of an outpatient kind of thing. But our diagnostic test we do a TTE, right? Everybody gets an echo, especially our heart failure patients, to see why are they here right now? Is the heart failure worse, right? They say, oh no, I know my ejection fraction, it's 62%, right? But then you do another echo and you realize that's 32%. Like, well, why did they get reduced so much? It's like, well, I went to the doctor 10 years ago, so that might be the reason why it's 32% right now, right? Or they have a heart attack. So how do you know someone has a heart attack?
Like labs or what?
Yeah, clinically you could say they got chest pain. Is chest pain a symptom of heart failure? Yeah, if it's poor enough output, it could. If it's poor blood pressure. But EKG can identify an MI, right? So do you have an MI in my hands, or do I do some tropes? Do I have to see if I have an MI? When someone has just straight up heart failure, that doesn't cause a rise in tropes, right? It's like, well, but it's failing. Does that mean it's dying? No, it just means it's failing over time. Okay, and then the pro-BNP can tell you how bad someone's heart failure is, right? And if they've switched from BNP to pro-BNP, it's a lot more sensitive, just like our high sensitivity troponin is more sensitive than our regular troponin. So there's different categories for where they should be at based on their age, whether they're 45 or 90, right, or between there. And then chest x-ray. Chest x-ray can tell us if we are in like florid CHF or with reduced ejection fraction. Do we have a cephalization of the vessels, which means that we have pulmonary vascular congestion. So we have fluid building up bilaterally, right? That's expanding to the sides, and you're going to hear crackles all the way through the lung fields, right? So there's are different things we can look at to see on X-ray is someone in CHF or not, right? To see if they have a CHF exacerbation. And then you can see here is a normalish EF, right? And over here, look at that EF. Right, it can barely contract. It can barely do it. And then what's going to happen? The S says, I got this, bro. All right, and it's going to go ahead and fire off the SNS. It's going to fire off the RAAS. The RAAS is going to fire off the SNS. The SNS and the RAAS are going to fire off the vasopressin. And then the vasopressin and the RAAS are going to retain fluid and sodium. And it's going to be a whole downward spiral, right? That we want to try to mitigate before, they develop a reduced ejection fraction, which the one already is, if they had a preserved. But that can then lead to, down the road, of cardiogenic shock. Okay, so that's the idea behind HFrEF and HFpEF and our diagnostic test that we do to fix to see if someone is in heart failure.